Welcome back. You're watching Monday Special. Before we begin our discussion, let's look at some numbers for you. These are the top 10 causes of death in Kenya. Let's see if we can list those for you. We have HIV/AIDS, and then influenza and pneumonia. We have diarrheal diseases, stroke, coronary heart diseases. I don't know if I'm birth trauma. Okay, there we have it. Low birth weight, tuberculosis, maternal conditions, and road traffic accidents. In just a moment, I'll be asking the gentleman from the Ministry of Health, because a lot of you have been asking, really, I thought breast cancer would be higher up, etc. So I'll ask him to explain that. And then let's talk a little bit about non-communicable diseases and see if we can get that on the screens for you. These are diseases that are not infectious and cannot therefore be transmitted from one person to another. In Kenya, NCDs cause over 50% of the total hospital admissions and over 55% of total hospital deaths. The most prevalent causes are cardiovascular diseases, cancer, diabetes. You can see the percentage on your screens, 13%, 7%, 4%. And then we move on to deaths due to coronary heart disease. Let's see if we can see that. There we have it. 13,488 annual deaths in Kenya due to coronary heart disease, 4.2% of total deaths. And then the risk factors, we have, among others, tobacco use, harmful alcohol use, and sedentary lifestyle. So let me quickly introduce my panel to you once again. Seated right next to me, we have Dr. Mohammed Jailan. He's the interventional cardiologist, assistant professor, director cardiology program, Aga Khan University Hospital. And then we have Saida Bakari, client service manager at the Standard Chartered Bank, and she survived a heart attack. She'll tell us a little bit more about that. And then we have Dr. Joseph Kibashio, head of non-communicable disease control unit from the Ministry of Health. Thank you all so much for joining me this evening. Before we get into coronary heart disease, maybe Dr. Kibashio, you can shed some light on the list that I just read out, the top 10 causes of death. A lot of people surprised. These are the latest findings. Why do we still have, for instance, HIV/AIDS at the top? Some people wondering tuberculosis is way down there. We don't have breast cancer there. Explain it for us a little bit.
Okay. Thank you, Janet. Let me start by saying that our country is in the middle of a transition, and I usually put it from 1963, from Uhuru in 63 to Uhuru, 2013. Those are 50 years from within which we have had a tremendous shift from the disease patterns that we see in this country. Initially, when Mzee was talking about illiteracy, disease, and poverty, he was talking of the infectious conditions. But now we are seeing a shift towards non-communicable diseases. And top on the list, you have described them there: cardiovascular disease, diabetes, cancers, and chronic lung obstructive diseases. And these, of course, the figures showed that top on the list still is infectious diseases, especially HIV and its comorbidities. But very fast and catching up non-communicable diseases. Let me just address the issue you said about cancers. When you unpackage the HIV deaths, HIV, you don't die of HIV per se. You, of course, die of multiple organ failure, or it can be a cancer, can be diabetes, can be anything. So amongst that, there is the cancers and also the general population cancer. It's not like cancer is not a major cause of illness and death. 28,000 people perish every year in this country because of cancer. So it's still a formidable cause. But when you look at it as per the organ, breast cancer itself might not be able to match up with HIV or cardiovascular disease per se.
Thank you for clarifying that for us. And remember, you can keep in touch with us. Use the hashtag MondaySpecialKE on Twitter or SMS us on 22422. We're talking about coronary heart disease, and Dr. Jailan, let me just start by asking you to define it for us. Earlier on, we were saying there's so many definitions and confusion between heart ailment, heart disease, coronary heart disease. What is coronary heart disease?
I suppose to think about coronary artery disease, you need to realize that the heart is a pump, and its function is to pump oxygen and blood to the rest of the body. Just like the rest of the body, the heart itself needs oxygen and blood to keep itself alive and to keep it functioning. The oxygen comes through what they call the coronary arteries, which are fuel pipes that are a bit like, if you imagine your heart is about the same size as your fist, and the veins that you see on your fist, you can imagine them to be like coronary arteries. So those are small pipes, but they're very important pipes. And if you have two pipes, one on the left side and one on the right-hand side, and if one of those pipes gets blocked, within a few minutes you'll start to develop chest pain. And if it gets completely blocked and the blood supply isn't restored, that part of the heart will die. And the heart will no longer be able to be pumping as effectively as it did.
Okay.
So coronary artery disease is a disease process within those coronary arteries, the fuel pipes that supply the very important heart pump that sends blood and oxygen to the rest of the body.
So coronary heart disease and coronary artery disease are one and the same thing?
They're exactly the same thing. And they result in the thing that people worry most about, which is a heart attack, which is a complete blockage of one of those pipes, one of those arteries.
Which you can survive.
Yes.
As we'll just find out from Saida.
As we'll discover from Saida. Of course, the heart has two arteries, and those arteries have branches within them. And a blockage can occur either in the main trunk of the artery or further down in the various branches of the arteries. So a heart attack occurs because there's been a blockage, an interruption to the blood supply to part of the heart. But it may be that that part of the heart is only a small part of the heart, and the rest of the heart can continue to pump.
All right, what I'll do, I'll come back to you. Saida, let me get your story, and then we can sort of unpack the technicalities about the heart attack and cardiac arrest as well. Tell us a little bit about what happened to you. You suffered a heart attack not too long ago.
Yes, thank you, Janet, to have me around with you in your program. It was 6 weeks ago, 20th February. I was actually walking to the office after I parked my vehicle. And it's such a short distance that you can't imagine. I felt some tiredness within like 3 minutes walk. And by the time I got to the office, I was sweaty, my chest was painful. It was actually a pain that I couldn't explain, but I could feel my chest was a bit heavy, kind of. So when I got to the office, I explained to one of my colleagues, and I told her, actually, Irene is my friend. I told her that I have a very painful chest in case of anything. So actually, she really, I don't know how to explain it, but I think she was my angel on that day.
Okay, so what then happened?
What happened is that we had a training. I got up out of my seat. I went to the ladies. I came back. I didn't go back to the office, but I went to the to a sitting area where where we get coffee, we can have lunch and whatever. Irene didn't see me back, but she decided to come and check on me. So in the process, I was actually sweating. The pain was still on. It was actually becoming worse. So she told me we're going to the doctor. I told her, okay, but my dear, I can't walk. I'm not able to walk.
So you couldn't walk. The pain was heavy.
It was heavy, so I was imagining from my office, there's a clinic at Muthithi Road. So I thought that's where we were going to walk to. I told her I'll not be able to walk, so she said, we are taking a taxi. We walked, we took the lift, we went down. She picked a vehicle out there. And I told her, okay, where are we going? To Aga Khan. I told her, let's go to Muthithi. She said, no, let's go to the main hospital because anything serious could be happening.
Okay.
So when we got to the hospital, we went to the Jubilee side. They took the nurse we found took my pressure, blood pressure. And I noticed she was shocked. She picked the phone and called the doctor within the area, but the doctor didn't come, so she had to walk there to get the doctor to come.
Okay.
The doctor came, confirmed the pressure was too high. So at that moment, I was like, the doctor was asking me, so how did you come?
Because you were actually suffering a heart attack.
Yes.
That was all you suffering a heart attack.
Yes, yes.
So then what happened thereafter? Because I understand after that, staying in hospital, you then went into cardiac arrest.
Yes.
Tell us a bit about that.
Actually, within that same day, we went to the hospital. They did some tests. And within the period that we were waiting for the tests to come out, I got another heart attack. And that's when Dr. Jaylan was called in because I was actually in more pain. And he confirmed this was a 99% heart attack. And all of a sudden, it was an emergency. I was taken to Cath lab where they do the procedures of heart problems.
Okay.
And they did a procedure where they checked on my heart, and my heart had vein that did not have a good passage of blood.
Okay.
Yes.
All right. Let me just cut in there. So interesting, because again, a lot of people may think that a heart attack means you clutch your chest and you fall down. That can happen, and yet it can also manifest in that way: pain, dizziness. So how can someone tell when they are getting a heart attack? Maybe someone just thinks it's a pain in my chest, I should just go take some medication and lie down.
I mean, that's an excellent point that you raise there, and very well and eloquently described by Saida here, that many people who are having a heart attack are not in the middle of a movie clutching their chest and falling to the ground. And one of the problems we have as doctors is convincing people that they're about to have a big heart attack, or they've had a mild heart attack that may turn into a big heart attack. Okay. And it's because they sometimes feel quite well. And especially the relatives see somebody feeling a little bit better. And when we caught up with Saida, by the time I caught up with her blood pressure has settled down, and actually the initial pains had settled down, and she was much more comfortable. And I was explaining to people around her that she was having a heart attack, and you know, trying to get people to accept that such a serious thing is about to happen is quite difficult. You have a window of opportunity, and that window is relatively narrow sometimes. And that's why people have to act quickly. But during that window, things on the surface look okay. Deep down inside, something else is going on.
All right, Dr. Kibasho, I'll bring you in just a moment. But very quickly, she then went into cardiac arrest. Explain cardiac arrest and the difference between that and heart attack.
So basically, a heart attack, as I said, is where a part of the heart muscle dies as a result of not getting enough blood or oxygen to it. Now, if that part is big enough, then the heart itself will actually stop pumping. And that means that there will be no blood circulating, and there will be no oxygen going to the brain. And the brain, if the blood supply is not restored quickly enough, the brain will die, and the patient will die. So a cardiac arrest is a serious problem. It can occur within 3 or 5 days of somebody's heart attack. So usually within the first 3 to 5 days of a heart attack, we recommend that people stay in hospital under observation in special cardiac care units, so that such things can be picked up
and treated.
And in Saida's case, that happened while she was in hospital.
So she was lucky, because it could have happened at home, and
it could have. I mean, she could have gone home, but luckily in her case, it happened while she was in hospital under observation, and within an hour or so of that occurring, we'd already opened up the artery that had blocked her blood supply.
So surgery?
Actually, no. Interventional cardiology is a new technique which allows us to go into people's wrists or legs and use special X-ray techniques. There's about 3 or 4 facilities of this in Nairobi that can now offer this intervention.
All right.
And we unblock the arteries without opening up the chest. So Saida doesn't have any wound on her chest, but you'll have a little puncture site from the point where we did the incision.
But that's where the cost comes in, very expensive, and I think I can bring Dr. Kibasho. I'm guessing it's an expensive procedure that not a lot of Kenyans are able to afford.
Yes. So interventional cardiology or angioplasty, which is essentially what we do, is one of various treatments for a heart attack. Blood thinning agents is one treatment. Blood clot breaking agents, blood clot forms inside the artery, and to break up that blood clot with a certain drug is another treatment. But the definitive treatment for a heart attack, and the gold standard, is to take somebody into a catheter lab, the cath labs you described, and to inject some dye into the arteries, feed a small wire through the blockage, and over that wire you feed a small balloon, and you open up the artery. And those balloons are expensive. They're imported, they're not made in Kenya, they're made in the US, the ones that we use. And the cost of the balloons and the stents is part of the issue.
We'll come into treatment and response, because I know you mentioned having worked in the UK and here, just kind of looking at the response and how that could save a lot of lives if it improves. Very quickly, before we take a break, Dr. Kibasho, tell us a little bit about policies for things like coronary heart disease in Kenya, seeing as these non-communicable diseases are now on the rise. Is there a special focus now that the government is taking to ensure that it's addressed?
Sure enough. Let me just start by addressing or probably adding to what Dr. has said. One of the biggest problems we have about non-communicable diseases are things we call myths and misconceptions. There is, for example, a misconception about the person who can get a heart attack. When you look at Saida, she doesn't look like the person who, in our minds, is the person to get the heart attack. She's not as old as you would imagine. She doesn't look very ill. So there's that misconception that somebody to get a heart attack, you have to be an old guy who is a smoker, who drinks, who is obese. Yes, those are risk factors, but that doesn't necessarily mean that everybody else who doesn't have that battery of risks or that battery of signs and symptoms then would get a heart attack. Coming back to your question, as I said, non-communicable diseases are on the rise. And this is manifest. Everybody knows it. For example, if today you are called back home that your parent or your auntie is sick, it won't be the malarias or the HIVs. It will probably be hypertension or a cancer or something like that. So every person has a rendezvous with these diseases. And as a government, we are not lost to this fact. In fact, if you look at how we are looking at diseases now, we are looking at it in terms of the cost effectiveness of treatment or of prevention. Now, it's very easy to change the course of a river from the source rather than right at the end of the river. Now, this is a big, big problem. And if you look at subsequent years, we haven't put so much focus on non-communicable diseases. That's why we are where we are, because investment were put on acute illnesses, which TB, HIV, malaria, which were, decimating a lot of our population. So we are in a position where now, from the year 2008-2009 budget year, and I thank the president because then he was the Minister of Finance, that was the first time when we had a substantive budget item for non-communicable diseases in the budget. And over the years now, we are seeing more and more focus on non-communicable diseases.
But is there enough awareness? Are you creating enough awareness to the public about it?
Beautiful. One of the biggest pillars of actually health practice, he's in clinical practice, I'm in public health more so, and I lean more on prevention and promotive. And this depends on a lot of, or rather, health promotion is about education and making people make informed choices. For example, currently, we have 4 major shared risk factors that we talk about. When you talk of non-communicable disease, diabetes, cancers, cardiac diseases, and lung diseases, all of them have 4 shared risk factors, which are tobacco, top of the list, alcohol, unhealthy diets, and physical inactivity, which we'll probably talk about later. But all these 4, when you address them, then you reduce your risk of getting any of these 4 shared risk factors. So as a government, our priority is actually on prevention, not forgetting that the curative part is very, very important. But we want to see 30 years from now, the investment we are making on prevention, it will bear fruits. Let me just give a quick example. For example, salt intake. One of the pillars that we want to go into is to reduce the salt intake of Kenyans, to reduce the hypertension rates. Dr. will tell you that one of the biggest risk factors of a heart attack is actually hypertension. We cannot stop hypertension tomorrow. This is a long-term process, and for example, we put mechanisms today that will bear fruit 30 years from now.
All right, I want to come back and talk a little bit about the global picture vis-a-vis what's happening in Kenya. You also mentioned you're seeing a lot more people, even in their 30s, getting heart attacks, which is shocking to a lot of people. And of course, we'll come back and take some questions on Twitter. Use the hashtag Monday Special KE. SMS us on 22422. We'll be back after this short break.
We have a lot of questions on 22422. Janet, if you allow me to read about 3. One here says, of course, most of them to Dr. Jaylan. I'm 44 years. Recently, after a chest x-ray, I was told my heart is big and my chest has inflammation. Are there chances of a heart attack? And then somebody here says, who can save me from heart disease? I'm very young and always think a lot about, especially about money, and I have a sore throat. And finally, somebody here says snoring, that is snoring and heart complications, any relationship?
Okay. Thank you for that, Hussein. We'll also be asking, I don't know if you want to quickly answer some of those questions. I think the first one was talking about heavy chest pain, if I heard correctly. And I've seen someone else ask that again, heavy chest with slow breathing. Does that sum up coronary disease, heart disease?
Okay, so I think the first question was about inflammation within the chest, seen on a chest x-ray. What I'd say about that is that it is not really a feature that you can pick up on an X-ray. Coronary artery disease isn't something that you may detect on a chest X-ray, and if they pick something else on the chest X-ray, then it's more likely to be something else. It's very difficult to discuss cases on a 1 or 2 sentence.
Because it has to be a lot more detailed.
But yeah,
we'll have more questions in just a moment. Another question here for you, Dr. Kivashu. Someone saying that what are you doing for people to be able to access health in various counties? Treatment seems to only be done in Nairobi. Any plans to spread it out there, and awareness as well, very quickly?
All right. It's good to realize that in the devolved system of government, county governments are in charge of, pretty much most of the hospitals and health services in the counties. But here, I must quickly say that I'm sure Dr. Jelan will be like, oh no, physicians are trained to, detect such problems. And considering we have only like 22 of his kind, it would be impossible for everybody to access a cardiologist if they had a problem with their heart.
Right. And that's an issue, Dr. Jelan, in terms of the numbers, the number of
yes, I think if you look at cardiologists, there are about 22 of us. If you look at interventional cardiologists or heart attack specialists, there are even fewer of us. And almost all of us are in Nairobi. There are about 1 or 2 that I'm aware of in Mombasa.
So that's
and the facilities to support that kind of problem, that's what we need to build over the next few years.
Yes.
And actually, as I was saying, it would be very impossible for the infrastructure. Even if you took Dr. Jelan to Kisumu and there is no cath lab or there is no facility for him to use for him to do his thing, then it would be a waste of resource. But it's good to mention here that the government is very reliant on private-public partnerships, and we are very grateful about the Aga Khan University Hospital who come in and supplement government efforts.
Another quick question: people are saying there doesn't seem to be enough campaigns or awareness for coronary disease. It's very low. What have you done in terms of raising awareness so far?
Okay, in terms of raising awareness so far, we are still going back. And probably, let me just mention this. In as much as the government is struggling to guarantee the highest standards of health, we must realize that non-communicable disease, the big end of the stick lies with the individual. It's very difficult for me to remove that beer from your mouth or the stick of cigarette, but we are ensuring that guys know the risk factors of cardiovascular diseases and other non-communicable diseases. So essentially boils down to education. And this is being done through community health workers, being done at the primary health facilities, and also through radio.
So it exists at the moment.
Yeah.
Very quickly before we go to some tweets, Saida, someone else asking, how are you living with it right now? And I guess she's cleared of heart disease now. Can I say that?
No, I think once you're detected, once your coronary arteries have got a problem, then we have to do everything we can to try and prevent that from happening again.
Oh, right, but it can happen again.
Of course it can happen, because it's a bit like a road with a pothole. You can fix the pothole, but if you allow the same kind of traffic to travel over that, then you're going to run into the same problems again.
Okay, how are you living with it now? How are you feeling?
Janet, I feel good. I'm comfortable now. I'm on medication, and the most important thing is to eat well, exercise, and live comfortably, no stress, nothing.
That's how your life has changed. What have you done to change your life that you didn't do before?
Okay, I'm doing some exercises. As at the moment, I'm going to rehabilitation at Aga Khan. At the same time, the day I'm not going for the exercises, I'm working out in the house.
Okay.
I walk a lot these days. Yes.
And your diet, and you just mentioned stress. You're trying not to stress.
Yes.
Trying to stay calm. Okay, that's good. Let's see if we can bring up the questions on the screens right now from Twitter. Some of the questions. What are the plans by Ministry of Health to deal from a fitness approach, prevention and management as opposed to the medical way? I think that's what we were talking about, sort of outreach and campaigns. What is the secondary prevention of coronary heart disease? Then we have, what are some of the healthy foods that a victim of coronary disease can use, I guess, to get better? What are the causes of coronary heart disease, and is it hereditary? What are some of the symptoms and signs of coronary heart disease? All right, that's quite a few. If you can pick 1 or 2. Hereditary?
Yes. I'll tell you my personal experience, because I came to Nairobi to practice at Aga Khan about 2 years ago, and I've been in England for almost 30 years prior to that, and I've probably over the last 15 years looked after 7,000 heart attacks when I was in England. And the thing that I notice is that Kenyans have a different pattern of coronary artery disease. We're getting heart attacks at a younger age. So if you look at the time to a heart attack around the world, in Africa we have heart attacks 5 years earlier than everywhere else in the world. And
Is
that
it
was
because of
very well
lifestyle?
described. It's clearly an environmental thing and definitely a genetic thing. The other thing is that, as I told you, most of us have two coronary arteries, one on the left and one on the right. We find that in our population in Kenya, as opposed to the population I served in England, people present at a younger age with more widespread disease. So the artery, it's not just one artery that has a significant narrowing. We're finding multi-vessel disease in our population. And that's something that I didn't know about, and we're slowly discovering this. And it's a very interesting and very worrying thing. There is definitely a genetic element. So you do have some people who have, you know, who've got families. I've got a family of heart attack sufferers that I look after at the moment, and they're African, they're Kenyans, from the Rift Valley.
All right.
There's definitely a genetic element.
Very, very quickly, just because of time, what's the youngest victim you've treated? How old were they?
Okay, so in Europe, the youngest was a 25-year-old woman. In Kenya, I've treated a 20-year-old heart attack victim.
20 years old?
20 years old.
Did that surprise you?
Yes, it did. I mean, even now, if somebody calls me and says, I've got a 23-year-old and I think they're having a heart attack, I doubt it very much. And it's very important to understand that it's extremely rare, but it is happening even at that age.
Someone, my director has just told me, someone on Twitter is saying they're 23 years old, they have severe chest pain. Are they at risk of heart attack? Should they be worried?
I think if you've got chest pain, and we discussed this earlier, more than 85% of causes of chest pain in that population have nothing to do with the heart.
Yeah, that's what we're talking about.
The heart has got lots of nerves in it, supplying the skin, the muscle, the tendons, the bones, the lungs, and the heart itself. And then there's some that's supplying the heart muscle. And so chest pain in itself, whilst it's an important symptom, is almost always in that sort of age group not related. However, you need a vigilant patient and a vigilant doctor to make sure that the most important of those causes, which is a heart attack, can be ruled out. And that can be done very easily nowadays with a blood test and an ECG.
Very quickly, oh sorry, you want to say something, Dr.
Just to throw in something small there to add what Dr. Jelani is saying. Most of the heart attacks, you'll find that occasionally there might be some mini, form of them that sometimes, people ignore, they didn't take seriously. By the time you're having an overt, serious heart attack, probably you had some, issues before which you didn't take care of. Now, the other thing you need to know is that there's a big delay, and I'm sure Dr. Jelani will be talking about this, and the question will come to us about ambulatory services.
Yes.
How available are ambulances, and how do I know that I have an attack? How do we reduce the time? Now, I've just said that with the reduced number of cardiologists that we have physicians who we just urging to have a high index of suspicion, just that any chest pain, not to ignore it, because we are in that phase where our epidemiological transition has happened. We are having more of these people in a younger age. Now, to mention about ambulatory services, you've seen county governments clearly doing a lot of work towards ensuring that ambulances are present. Now, insofar as an ambulance is available, there's also the issue of the referral chain. Sometimes we overwhelm the national referral hospital. Let me just talk about Kenyatta. Any condition can be dealt probably at the health center or at the district hospital, at the provincial hospital, all those levels, before we all converge at the casualty in Kenyatta, leaving physicians all away. And it's also good to understand that we might not be able to have the capacity that Aga Khan or Nairobi Hospital may have. But these two hospitals, or 3-4 hospitals that he has said have cath labs, we are working very closely to see if we can use their capacity. For example, if I may just talk about the hospital Jalan works in. At night, the cath lab is closed. And, we could use these facilities when they are down. For example, the cancer chemotherapy machine. People are lining up in Kenyatta. What if you opened your hospital up at night and we, used it for, a subsidized cost? These are things we are trying to explore to see how the overwhelming, whatever in Kenyatta can at least be eased.
If I can just clarify a point there about the cath lab being closed. Heart attacks occur at any time of the day. They happen at night more often than they happen during the day. And so there's always a heart attack service, particularly in our hospital, so that if you have a heart attack, you don't say, I'm going to wait until the morning with the cath lab.
All right, you can still...
I'm available all the time, and so are the other interventional cardiologists, and the cath lab have got an on-call facility. And that's very important because, as you pointed out, many people who have heart attacks come 12 hours late, or they don't make it. In fact, in England at the moment, and more so in Kenya, but in England at the moment, half of the people who have a heart attack do not make it into hospital.
They pass away.
They die before they get into hospital. And that is a big problem. That problem has significantly reduced over the last 20 years in that part of the world, and we have to catch up with it in Kenya. And we will catch up with it. And I think we've got a lot to learn from what mistakes were made in Europe, so that we can do ours. We can do things a bit better.
A few more questions. I understand that coronary heart disease happens slightly differently in women compared to men. Explain that.
No, actually that's a misconception, that women are very likely, and in fact what tends to happen is that women are considered unlikely to have heart attacks. As I mentioned, the youngest person I've ever seen was a young 20-year-old woman with a heart attack. Women and men should be treated just the same and should be managed just the same. It's important to understand that a heart attack presents in different ways. Some people don't get pain in the chest. Some people get pain in their right arm. Some people get pain in their left wrist. Some people get pain in the jaw. Some people get pain anywhere above the navel and below the upper jaw. Could be
all related.
Could be related.
Wow.
If you have the associated symptoms that Saida described, like sweatiness, general acute weakness, if you have those things and you've just got a discomfort in your left wrist, that could be an important thing. And so a vigilant patient accompanied by a vigilant doctor, who the combination of that, seeking help early, may save a life.
So someone might ask, when should one see the doctor? Every time they have a slight pain, or, you know, again, a question that's been asked, because some people might get paranoid. Should you, is it when the pain is severe? Is it when there's slight discomfort? What would you advise? I know it sounds like a very general question.
It's a general question. Usually, so the general advice is, if you have pain that persists, that's out of the ordinary, and it lasts more than 10 minutes, and it's still there, and it's associated with some of the other symptoms, then you should probably get it looked at.
Or an unusual pain that you've never experienced before.
Like in your case?
Yeah, like in my case. I mean, that's something that I've never felt before, and I felt uncomfortable.
Yeah. First aid for someone who's experiencing a heart attack? What happened?
Get to a hospital as quickly as possible. But very important, take aspirin, 300 milligrams of aspirin. If you're suspecting a heart attack, it's something that thins the blood, and if there's a blood clot that's formed to block the blood supply, it will help melt the clot away, and it starts to work within 15 to 30 minutes. So some people have taken 300 milligrams of aspirin. By the time they arrive in hospital, they're a bit better. Of course, they need further evaluation and treatment, but the initial damage may be limited by taking a little bit of aspirin in a timely manner.
At this point, I could just add that an ambulance is not just a vehicle, and probably just a challenge to some of the counties, that the ambulance should be able to sustain this patient from, you know, the point the heart attack appeared to in hospital. You know, oxygen should be in there. There should be blood thinners. There should be equipment that would resuscitate the heart if it stopped in the process. So we have these towards buying the ambulances, but I would rather we buy 3-4 ambulances that are, you know,
fully equipped.
Fully equipped.
State of the art, as you're going to say. Food, someone asked about food. I think they asked what food can they use, or what foods should they take or not take. I don't know whether you can touch on that very quickly, any one of you.
So most people, when they talk about diet, will say that a healthy diet is a balanced diet, and everything is safe in moderation. The key amounts are difficult to describe to this audience today, but what I'd say is that things that are not good to be taken are things that contain a lot of cholesterol, particularly high in cream, milk, butter, red meat, food that contains a high amount of salt. And just to go back, our bread contains about 60% of our daily salt intake can be contained in about 2 or 3 slices of bread. That might be a focus maybe for future government intervention. High salt intake, these are things that put you at risk of the underlying processes, high cholesterol and high salt and high blood pressure, that put you at risk of a heart attack.
All right, Said, if I can just, oh sorry, do you want to add something?
Maybe on the diet, and I'm happy that Dr. Ari has not prescribed a diet. You know, most of the times you go to the hospital, you're told the diet for person with heart attack is this, the diet for person with diabetes is this. No, we're just saying that a healthy diet, and we move away from the balanced diet, because a meal of 1 kilo of meat, a small piece of ugali and a few vegetables is still balanced anyway, but is it healthy? So we need to move towards healthy diets. Now, the thing we need to avoid, as Dr. Ari said, is high salt, and he has said it's not on the salt shaker. There's a lot of processed foods, and as he has said, we're trying to see how we can engage the food industry to either regulate themselves before we try and regulate them, because the biggest salt intake is out of my control. The bread I'm eating, I cannot remove the salt. It's already been put in there. So salt, few servings of vegetables. People don't eat vegetables, people don't eat fruits. And then there is food that is high in refined sugars, the fizzy drinks, and also large portions of food, especially cooked with the wrong kind of oils, the saturated oils, especially the shortenings.
It's interesting, there's so many factors that need to be taken into consideration. When you talk about even the food industry, it goes beyond that to look at how to improve the food that we eat. Saida, if I can quickly ask you, how your family took it, and how they are they a lot more sensitive around you? Are they very delicate around you now? Is there a sense that
I can say they are quite delicate, and I think it really affected them when it happened. So at the moment I can say everything is okay.
Okay.
Yeah, they're coping with it. And I'm also coping with it, because I need to talk more about it so that I can also educate other people about it.
What would you like to say to someone who's suffered a heart attack? And I mean, you seem vibrant. You've come on the show just 6 weeks later, and they're living in a sense of fear and paranoia. What would you like to say to them?
Actually, I need to ask these people to actually talk about it. That's the most important thing. They shouldn't hold it to themselves. They should exercise. They should also go on to diet and keep the medication that they are taking.
Okay.
Yeah.
Quickly to the panelists, I know you all raised the disclaimer about smoking. Is something you want to say about that? Maybe we can start with you, Dr. Kibasho.
Thank you. Tobacco is the single most important risk factor that you're talking about when you're talking about cardiovascular diseases. And I want to reiterate here that the Tobacco Control Act of 2007 actually has a lot of elaborate ways of curbing this. And I want to throw a challenge to the governors. A lot of tobacco control initiatives have held place in Nairobi, but I want to ask them to implement these across the counties. And also to say that most of the tobacco that we see now is changing in form. We have a lot of young people smoking shisha, very naive. It doesn't look like it's tobacco. For sure it is.
Okay.
And will cause them some health.
Well, thank you for that. Dr. Jailan?
No, cigarettes are absolutely a very serious concern. In China, one of the major causes of this sudden rise in coronary artery disease in that country has been the high prevalence of cigarette smoking. It's a problem that we see more and more in our country, and we do know that initiatives outside our environment in Europe and in the US, cities where they've actually limited access to smoking areas, prevented smoking in public areas, have resulted in improvements in cardiovascular death.
All right, thank you. You said you had a message.
Yeah, but I think it's already been
answered.
Tackled in terms of smoking here.
Okay.
Yeah, okay, I'll read two questions. Two comments.
Two comments, right.
Janet seems baffled that I'm here, but it's all right.
Yeah, I don't know why you've come.
Somebody here says, good show. I think this is a message that needs to be driven by the corporates, employers too. I think Dr. Kibasho talked about that. And says, hi Janet, I'm Beatrice. Saida Bakari is my boss, and I wish her a quick recovery. And we do as well.
We do. Yeah. And still, thank you so much for coming. Yes, of course, also at CK Ogutu saying I've learned a lot from the discussion, so much that I didn't even know. And a lot of you asking questions, most of which we hope that we answered. Thank you so much, as always, for engaging us on Monday Special. Many thanks to our three panelists for educating Kenyans. I'm Janet Mbogwa. Thank you for watching. Good night.
Good night. I'm Hussein Homer.